there's all these extraneous rules that are invented to try to maximize revenue as opposed to wellness. And so what we've said with Cost Plus Wellness is, okay, how do we eliminate all of that?
Welcome back to the podcast for doctors by doctors. I'm Dr. Michael Jerkins.
Dr. Ned Palmer.
And we are excited to present our conversation, our second half of our conversation with the one and only Mark Cuban, where we talk about all sorts of additional topics in healthcare and other topics too.
We do. I'm really excited to bring this after our part one conversation where we dove very deep into pharmacies, pharmacy benefits managers, Cost Plus Pharmacy, what it's doing. And to get broader here, talking about, I'm really excited to explore with Mark his other passions. So healthcare, sports, which we've alluded to somewhat, some of his interests in politics and how that intersects with the healthcare game.
Yep. I think I learned a lot, especially on part one on pharmacy. I learned a lot on part two on policy, and thinking, again, his big thing is transparency. And so really excited to present the second half of our conversation with Mark Cuban.
How do we extend the transparency? I love the argument that transparency is there. The ACA tried to do a lot and keeps pushing for transparency from hospital pricing, procedure pricing, CMS's charge master list. How do we push transparency further?
Okay, so on the hospital side, right, the challenge with hospitals, all those prices are great, right? When there's single instance type support or mediation, right? However you want to describe it, right? Whenever the care is only a single transaction, it's really simple, right? And what I tell our folks and what we do is here's the company credit card, walk in there and ask for the cash price. And if it's simple, like if it's an MRI, if it's an X-ray, if it's fixing a broken bone, even if it's, a hip replacement, then you get a single price and the cash price is always lower. And it's crazy to think that the biggest insurance companies, when they negotiate, the price that they negotiate is much higher than the cash price. And the reason for that wasn't initially intuitive to me, but it's obvious now. So when somebody goes to the hospital to see you guys, for whatever reason, right? Whether it's emergency room or scheduled or whatever it may be, 99% of the time, if they're insured, they have a deductible or copay or coinsurance, right? And the coinsurance that, if it's an operation that's going to cost more than a couple $1,000s, there's a really good chance the amount's going to exceed, their obligation, right? So they're going to have to pay their full deductible. And most people, there's an affordability issue, but the bigger point here is that the hospital or the provider or your practice is responsible for the credit risk. And literally, depending where your hospital was located, you might have, a 60, 70% write-off of all your deductibles. And so if you pay cash, that deductible risk is gone. But wait, there's more, right?
There's also the insurance risk, right?
Now,
like on top of the deductible risk and your rejection risk. Yeah.
Right. So let's just say, if they don't have insurance and it's a cash pay, that's a different beast, right? Because you're dealing with a different type of circumstances and there's dish reimbursement and all that. And if you're profit versus, so let's put that aside for a minute. But let's talk about with the insurance companies. It's a given that they're going to want to pre-authorize. Right? Put aside the deductible. The deductible is also a risk. So they're going to go through it, even though they know it has to take place, right? This has to happen. They're going to, deny it very often, right? And then they're going to put the onus on you to explain it. And that's going to go not only to you, but to whatever support you have and whoever else is at the hospital or wherever you work. And that's also a burden and overhead that's involved there. And so finally, you'll more often than not get it approved, right? They just try to delay you so that the patient, maybe comes back, miraculously healed. I don't know, but then,
yep,
yeah, or not, right? And so then you do the work, and they bill whoever the client is, right? More typically, it's an employer, right? And so that employer, they get a bill that's going to be higher than what they negotiated with the patient, with the hospital rather, with the provider, right? So there's spread pricing there. But wait, there's more. When they decide to pay the hospital whatever it is that they're going to pay them, they always short pay. Always short pay. So a couple things happens as a result of that. One, that the legal department has to get involved to try to contest it, and the administrators have to do all the administrivia to support what, each the hospital, the provider side. So that jacks up your cost. That takes up a lot of real estate. That's a lot of administrative overhead, right? And the estimates that we've been told is that's about 2% of revenue that they end up getting underpaid because the insurance companies short pay them, right? And then from there, you've got to have all the people in place to deal with the pre-auths and getting that approved. And then, all the other, so what Cost Plus Wellness looks at and says, okay, we're going into hospitals and we're saying, number one, before we even talk to you, anything we negotiate, we're going to publish. Because the reason the insurance companies like the PBMs are able to get away with this is because there's no transparency. You don't know what another hospital provider or practice does because the first line in that contract says you can't talk to anybody else about what you're doing, right? And the response a lot of hospitals have because of all this, incremental costs, that are added, they start inventing all kinds of costs and complicating things, right? Right. So you have facility charges that came out of left field, right? And which is insane, right? You get the, inflated Band-Aid charges that we've all heard about and whatever else that they can think of, right? Everything they could possibly charge, they are going to charge you for because they know that the value chain is such that everybody's got to arb their piece, right? Everybody's got to extract whatever rent they can wherever they can because they know the insurance company has complicated everything. So you'll see things to the extent that, if they stay 4 days, well, I'll tell you what happened to my mom when she had cancer. It was brutal. And this pissed me off to no end. She had lung cancer and they told her she had lung cancer. We got the scans back and then we wanted to do a PET scan, right? She was in the hospital and they wouldn't let us do a PET scan because she had to leave for 3 days and then come back to do the PET scan. And, hell hath no fury, like me pissed off, right? And so, and this is the hospital where I grew up and and so I was pissed. But it just goes to the point that there's all these extraneous rules that are invented to try to maximize revenue as opposed to wellness. And so what we've said with Cost Plus Wellness is, okay, how do we eliminate all of that? Because if the basis of all these extraneous charges and arbitrage efforts is the fact that nobody gets paid what they expect to be paid, right? There is no true transparent pricing. And the more complicated the event, the more complicated the pricing. And the greater the opportunity for the pricing to be complicated by the provider and see that as a revenue opportunity. Because my mom's got cancer. Who the hell is going to be upset? You're just going to, and Mark can afford it, right? Just give him good care, right? Right. So you just grab everything you can. So what we're saying is we're walking into providers and saying, okay, we're going to trust the doctors. Until you give us reasons not to trust the doctors by doing, too many of everything, and we'll be transparent. So you'll see the data, we'll see the data, and you'll know and we'll know up front if it's a bad doctor from a performance perspective or a bad doctor from a revenue, they're earning a commission perspective, right? And you guys know exactly what I'm talking about, right? And so by being straightforward with them and upfront that we're going to publish everything, then that creates a level of honesty because we're saying we're going to give you all the money we promise you and we're going to give it to you upfront, right? So everything that we contract for, everything that is in this deal, when Ned or Michael says, okay, Mrs. Cuban, you have lung cancer, unfortunately, you've got to do A, B, C, D. We're going to say, okay, we believe you, we trust you. We've negotiated based off all the DRGs and everything we can think of. This is the price. And actually that price ends up being relatively close to the Medicare price, in some cases even less, because you're guaranteed the minute, in this case, Mrs. Cuban walks into the hospital, she's got her credit card, and it's being paid immediately, or we've already sent you the money, unless some places prefer to bill because that's their systems and we have to pay within 15 or 30 days. Either way, you're getting your money relatively upfront. And that reduces all that. There's no deductibles. There's no co-pays. There's no co-insurances. There's no payment risk. There's no negotiation. There's no pre-auth, right? It is Ned or Michael said, this is what we need to do. Yes. This is the price we negotiated. Yes. If anybody's unsure about what that price is and how it was calculated, here's the contract online. Yes. Everybody gets to look at it. And when every other provider either looks at it and likes it or doesn't like it, because some big hospitals and some big brands aren't going to like that because they want to be paid a premium for their brand. And that's fine, right? There's certain places you want to go because you think they're the absolute best, or they have this doctor or that doctor who, can do this operation or whatever it may be. Great. You get paid more, but if you do a deal with us, even though it's higher, we're all going to know what it is up front. And there's no pre-auth because all these things just introduce more and more stress to the system and cost. Stress to you guys in terms of the system, and cost in terms of all the games hospitals have to play, all the extra administration, all the real estate for those administrators, all the overhead and benefits and everything for all those people as well, all the parking spaces, right? All the cafeterias, all that shit adds up really, really fast to increase the price of healthcare. And we feel like by paying up front and going to using us as, eating our own dog food and using us as the first case, and then letting people copy us, the same thing will happen. It'll be slower and take a lot more time because it's a lot more complicated than just issuing a prescription. But, and even like with CAR T therapy and everything, where you have to bring people in and all these high-end specialty therapies now that are going to cost $1 million and they have to be administered, that's on the healthcare side. And even these contracts will apply to that, right? And so by being transparent with our contract, everybody gets to contrast and compare and learn. And, we won't get it right the first 5 iterations, but hopefully by making this public and everybody telling us how stupid we are on these 17 different things, everybody will get smarter.
Yeah, it sounds like you've built a really interesting, blended model of some of the benefits of a capitated model, right? Which is, there's a lot of policy advocates, and we've had one on our show, who's very much in love with the idea of a capitated model, but then some of the value of at least a transparent fee-for-service model. You have a captive population you want to deliver value-based care to, but at the end of the day, the rubber meets the road, and you still have to pay for episodic care. And so at least bringing that transparency and shining a light on it.
Well, that's the whole point, right? Because why do you do capitation? Because you want to push off the risk, right? It's just a risk mitigation thing because you don't trust there's a lack of transparency, and you don't trust the people defining the prices, right? And it's the same thing with value-based care, right? Sounds great, right? We think that this is the value of a hip replacement. We think we can save you 75%, right? Because this is the average price. But how that reference price is set is everything, right? And so if it's set off a system, if it's based off a system that is inferior or cheating in a lot of respects, the value, you're not mitigating a lot of risk or reducing costs, relative to what you could accomplish. And so that's why we're doing what we're doing.
Can you talk a little bit about, as far as the strategy on the wellness side, of where you're going to really see the demand and where you're going to start with? And one slightly biased take is just, and Ned and I see this on these critical access hospitals, these rural hospitals shutting down. They don't have the overhead to play these games and the condensed or compressed margins, I should say. Are they in the market for you guys to approach on this wellness piece?
Yeah, of course. But the problem isn't their pricing, as you said. The problem is just the population, right? And the ability for the population to afford it. But if it's transparent, at least wherever their support may come from, whether it's communities within X number of miles, the state, federal, whatever it is, at least there's a hope for transparency. Like, I looked at literally buying a hospital just to be able to prove the point, right? And it was a community hospital, but they had so much debt that they had put against it, right? And their projections were so insane relative to the population. And really, you talk about capitation, that the best model that we considered in doing this is charging, almost like season tickets to the Mavs. Like when there's a new team that goes to a new market, like when the NHL went to Las Vegas, they said, well, if we can sell X number of season tickets, then we can afford to come, right? Well, the same thing applies to a hospital. If we can get X number of families and businesses to commit to $25 or $50 or $100 a month, for at least a 3-year initial contract, then we can afford to put a hospital here for you, right? And we understand not everybody's going to be able to stay up with that obligation. People are going to lose their jobs and yada, yada. But as long as we hit X% penetration of it, fine, right? And that's initially, I think it was in Chicago, the initial concept of insurance happened. There was a hospital that was about to go out of business, and they got the local community to pay them up front.
Buy a subscription,
right?
Well, it's like direct primary care now.
For sure, right? And, it's all about risk mitigation. And when you're in a rural area, risk is just far harder. It's just harder to reach that threshold of break even because of the uncertainties based off the amount of population. And it's a vicious cycle, right? Because people move because they don't have access to care. People have to leave because they lose their jobs because they don't have access to care. You guys see it more than I do.
And the big thing there, and Ned can speak to it more because he works in a critical access hospital very often, is that doctors, there is an argument on if there actually is a shortage or not. We've actually had someone else on the show that argues there actually isn't a shortage, but there is a maldistribution, right? So we're all concentrated in the same general areas. So even if, and I think I've heard you say this other places, of just because you have insurance doesn't really mean you're healthier. Just if we got everyone insured doesn't mean everyone's healthy. Eventually, they actually have to receive treatment somewhere and some allocation.
Nobody dies healthy, right? Nobody dies healthy. And so, back to your point, in terms of care act and access, it's hard to reach. You're talking about mitigating risk, right? So even like for primary care or for concierge care, why do they charge me a monthly fee? Why does my doctor charge me? They charge me for access, but they all just they do it so they can hit their nut immediately. But going back to doctors, that's what I was trying to get back to. There is not a shortage of doctors, but there's a misapplication, to your point, of doctors because of how they have to pay for med school, right? If med school was free, you would see a completely different distribution of doctors by specialty, right? We wouldn't have as many dermatologists, or orthopedic surgeons, right? Right? Because there's just, they go there. Why do they rob banks? Because that's where the money is,
Willie
right?
Sutton, yeah.
And so, Willie Sutton, right? And so, I've been an advocate and said this many times that I think med school at public universities should be free, right? And there are programs actually in place that, if you're willing to go work in places where there's doctor shortages and deserts, etc., they'll reimburse you, but you still got to put that money up front and you still got to pay it up front. And that's difficult, man. It's scary as shit to have to borrow, for you guys to have to borrow that money. And so I think med school should be free with an obligation, right? And, or you can just pay it and just go be orthopedic or do what you want.
Ned, what was our combined debt, you think, for med school?
$740,000 between the two of us.
Yeah.
Peanuts. That ain't shit, right? You guys are bitching about something, man.
Several beautiful homes or one piece of paper. Yeah.
Right? Well, you put it on black.
That's exactly right.
Away, right?
Yeah. Well, and what's frustrating a little bit about that, just to stay, is like there are programs that exist. There's a National Health Service Corps, which is the nationally provided program that was set up, I think, probably 15 or 20 years ago now to pay for doctors to go after their training and go to rural areas. But they haven't kept up the gift with the reality of med school tuition. So $50,000 of forgiveness is, frankly, look, I graduated, as Michael knows, like I had $420,000, he had $330,000. Like it's crazy to say $50,000 is a drop in the bucket, but it is a drop in the bucket. Like
no. So if you do the math right, at any given time, there's about 9,000 doctors in med school, right?
Okay. Yeah. I would have thought more. I thought it was
Yeah.
20.
And so
There's about 30 or 40,000 at each match that participate. So it's probably more than that.
well, okay, I'm sorry. Each about 9,000 in each class. That's what it was. It was each class. Right.
Yeah. Sorry, each year of going through. Yep.
Yeah, each class, right? So if it's 36,000, let's say, and it's $100,000, right? Each, right? And so you just do the math. And is that cheaper, right? Is it 3.6 billion? I don't know. You do the math or 30, whatever, 3.6 or 36, right? It's not de minimis amount, but it's cheap relative to the impact.
Yeah, and the interesting thing, Ned, we talk about this a lot, is there's really no accountability with the schools, right? So, I mean, the school gets the money from the government. What incentive do they have to keep the prices low?
Well, no, you can't write. Yeah, you've got to give it to the doctor to make a decision with.
And
right?
so the debt cancellation thing, which of course I want people to have less debt and student debt. I'm an advocate for that. But my issue is it doesn't really solve the problem when the schools are still going to continue to charge and charge and charge.
Well, that's a whole different thing, right? Yeah, because when you have easy money, that's an incentive to raise tuition and raise all your costs, right? Because they know the students. So I've had other conversations with, put a cap on how much you can borrow. Families can borrow from federal sources, right? Because, or, talking to the Harris, the people I know in the Harris camp, it's like, look, you put out to bid one school per DMA, right? One school per region. And you let that school win to be the free school. Whoever, and you make it a 10 or 20 year contract. And so now all the other schools have got to compete with the free school. And that is opposed to college is free, right? Because that just means they're just going to jack up what they charge. It's the same thing with Medicare for all. It's not that that's not a valid opportunity. It's just the PBMs and the hospitals are smarter than the government, and they're going to string them up and grab every penny that they can get until it's completely transparent. Once it's completely transparent, and you can say, and you have all the claims data and the PBM for Allegheny County and Pittsburgh, Pennsylvania knows all the claims, right? Then they can say, okay, we have the budget to pay that, so we'll make pharmacy free for all the citizens in our county, right? Which is comparable to what Canada does by province. They have a budget, right? But in Canada, they charge just like we do. They charge the provinces kind of like we do here when it comes to healthcare, right? And so, if there's no transparency, it's impossible to get the best price.
We've beaten up the schools appropriately. Department of Education, hospitals and healthcare, prescription policy. What do you think's going right in the healthcare system?
I think you've got good doctors. Obviously, doctors still care. Out of 990,000 practicing or whatever the number is, right? You're going to have some, bad apples, but doctors still care. Nurses still care. People still trust their doctors. That's what's going right. Doctors are continuing their education. We're going through a period on evaluating AI for better or worse, right? And so AI is a tool, right? AI has become a typing hack as much as anything else, right? Where you can get the AI to do the initial typing and you just fix it, right? Like before, where you have an assistant do it, before your assistant typed everything and then you reviewed it for the changes. Right now, AI can do all that. It's also nice just to ask it for a suggestion. Oh, that's stupid. That's an hallucination. Or I didn't think of that. That's a good idea, right? But the challenge with AI on a macro basis, I think, if you want to go in that direction.
I do. I'm fascinated about your approach to AI and healthcare. Yeah. We have varying opinions between the two of us.
Yeah, of course. There's a lot of opinions to be had, right? But, and I've had conversations with people in charge of healthcare and AI at Microsoft and in other companies, right? And so what I told them is the challenge is branding, because there's not going to be 5 or 2 or 1 major healthcare model, right? That everybody connects to, because like we mentioned earlier, MD Anderson, Mayo, Stanford, right? They ain't sharing shit, right? They're paying their doctors a premium and they're paying for research for a reason, because they want that prestige and information to go to them first and foremost, with them having the ability to share if and when they want to share. And without everybody contributing, right, it's kind of not very effective. AI becomes ineffective and almost a negative unless you understand who's been excluded from the model. And so for the basics, great, but you're not going to get all the information that's fit to print, right? In a research report, in a model. If it's
well, it's interesting. You're describing what I'm hearing is, under the ACA and some of the meaningful use rules, one of the biggest ones was sharing of health information between health systems, right? And that hasn't happened. They've completely neutered that. They've made, I would say, just an absolute lip service to doing that, right? It's really just consolidation of the electronic health record.
And that's patient information, right? That's patient information.
And that's patient information. That's patient-owned information.
Right. Yeah. And that's all siloed into like the most locked down silos that you could ever possibly imagine, right?
And you're describing the same for AI now. Like, they'll be the Harvard model, they'll be the Stanford model, and they'll all take and feed their own data in and concentrate.
Let me just tell you, there are going to be hundreds of millions of AI models, not 10, 20, 50, hundreds of millions. My kids are teenagers now. Do you guys have kids?
10, 8, and 5, almost 6.
So the 6-year-old, the 8-year-old, maybe the 10-year-old, by the time they're going to college, will have their own model.
Based off their own data, probably, right? Wearable data.
Their own data.
Yeah, I talked to my son about this, who apparently then at school goes and has philosophical questions about how AI is taking people's jobs. That's not coming from the home. I don't know where he's getting that, but...
Or how they can use it. Like my daughter is about to be a junior at Vanderbilt, and we talk about, the words that trigger teachers to let them know that whatever she did was done in AI, right? And how you can't use ChatGPT all the time. You got to mix it up. But you still have, and then I tell her very directly, you still have to know when it's hallucinating. So you still have to know the subject matter. So you can't cheat with it, but you can shortcut with it. And, you saw the thing with Michael Cohen, the Trump guy, the former Trump guy, who turned in, and it turned out that they used law cases that they hallucinated that didn't exist. That's the risk. So it's not going to solve, you can't solve against that. There's just no way to prevent hallucinations because AI doesn't have wisdom, right? If you ask AI, tomatoes a fruit, right? If you ask AI, can you put tomato in a fruit salad? They'll say yes. Nobody puts a tomato in a fruit salad, right? That's wisdom, right?
What kind of sociopath would put a tomato in a fruit salad?
And so there's no wisdom in AI. There's knowledge, there's information, but when it tries to create wisdom, if you will, that's where it hallucinates because
I heard it described as a stochastic parrot, which was one of my favorite, nerdy definitions of it, reading an article about it.
It's autocorrect. It's just a big version of autocorrect.
You had mentioned about talking with the Harris camp on student debt. And what's interesting, Ned and I were talking about, is in this presidential campaign, we haven't heard much about healthcare. It's not a major piece, at least, that's being talked about by either campaign, which, of course, I have my own opinions about. I'd love for that to be top of mind. But are there any politicians you're hearing on a healthcare policy, just given your experience and that are actually getting it right, that have a clue?
I'm not going to talk about the Republicans. How I feel about them is very public. How I feel about their nominee, Republicans, I'd probably vote Republican if it was a non-MAGA candidate. But so let's put that aside. On the Democratic candidate side, let's just say she hasn't put out policies yet because it's too soon. And the reason it's too soon is it's only been 3 weeks. And if you think about, let's just say you were the VP of a hospital, the board of directors just removed the CEO, and you followed the CEO's course, right? Where every doctor thinks they know everything, right? And so if you're a doctor and, you become the head of the hospital, right? Whatever the previous head medical, whatever the CEO did before, that was garbage, right? And so now I need my own people. I need to reformulate my own strategies, my own policies. That's what she's doing. People first, strategy second, policies. And she hasn't got to the point where she's ready to, not define, but publish, and release her policies, the details, which is fine, right? You don't have to do it now, but, and she's getting a lot of pressure to do that. And I'm not saying she listens to me. I'm sure she doesn't, but the people I talk to around her, right, they get that, right? They get that there's no rush. Like today, the CEO of Starbucks just got fired and they replaced him with somebody from Chipotle, right? That person coming in isn't all of a sudden going to say, day one, here's all my I'm going to learn all about all the people. I'm going to learn what the issues are. I'm going to learn about the culture. And then over time, we'll come up with a 100-day plan.
Makes sense.
That's what Harris is going to do. And in terms of how she feels, I mean, let's just say Biden got an earful from me, but it wasn't he was more concerned with Medicare. But the Harris camp has gotten a dozen earfuls from me, and they know all about Cost Plus. They know all about PBMs now. They know all about the good and the bad of the IRA, and, you know, the good of the Medicare caps at 2,000 for next year. But they're formulating it, but it's going to be, I don't see it, and this is just my guess, I don't see it going to anything like very super progressive. I think they understand that without transparency, you can't get a progressive solution.
That's right. That makes a ton of sense. Ned?
If it were yours, if you did have not just Vice President Harris's ear, but also some authority and control over it, like where would you see, like driving towards transparency, how do you policy-wise drive towards transparency? Because it seems we've seen that and they've been interdicted by.
So you just say very simply, you go to Congress and pass a law saying every medical contract must be redacted for personal information. And
that's it. And just create a database like the Sunshine Act, right? We've done public databases before. So there's even a precedent for it.
Yeah, you just publish it. I mean, it's really easy. And people will put it into AI. You can search and replace on, right? You know, you can download it and review it and analyze it and scrub it however you want and use it, because once you have that transparency, the market starts to become efficient. And the minute someone, you know, that's not to say someone couldn't abuse it, and someone, you know, there's regulatory capture and there's scale capture. The reason these big three PBMs have gotten so much business is, you know, there used to be a saying, no one ever got in trouble for buying IBM. Now, you know, CEOs, you know, even at your hospital, like I've talked to hospitals, world leading hospitals, and I've asked them about their PBMs and their insurance companies, and they don't fully understand how they work, right? And the issues, right? And a CEO of a company, typically that's not their core competency to know. And so by creating transparency, by, you know, if I was in charge of healthcare, create transparency, go and meet with all these big CEOs and explain to them how all this shit works, right? And how they're getting ripped off. Telling them, you know, yeah, you're getting rebates from these PBMs, but let me just tell you, you think the manufacturers pay for those rebates, but it's your sickest employees that actually pay for it, because the higher the rebate, the higher the deductible. And who has to pay up to the full deductible? The sickest employee, right? And if that employee has, you know, let's just say you have great insurance and it's a $1,500 deductible, but somebody's making $50,000 a year and after taxes, $30,000, now 5% of their income they have to have in cash off the bat, forget it. People just don't have that kind of cash to go pay that deductible. Now they're going on their credit cards, and it's just the slippery slope to financial health.
Terrible. Well, I know we're wrapping up and you're super busy. I had a couple of true-false statements. All right. True-false. AI advances will result in net job loss over the next 10 years. True or false?
False.
Okay. The Celtics will repeat as NBA champs next year. True or false?
Double super false.
Sticking with sports, LeBron James will be on the next Olympic men's basketball team.
False.
True or false? Donald Trump will win the election in November.
It's been fun, you guys. I'm not going to jinx myself.
Well, one last question, though. We always ask this to our guests. What is one thing that you've recently changed your mind on? We as doctors, we're presented with data. We change our minds all the time. What's one thing you've changed your mind on? And then we'll wrap it up.
Oh, my God. It was on Twitter. Somebody convinced me.
I've never heard that sentence. That is just, can we just pause for a second?
No, I know, right? It was whether or not algorithms used on social media are a form of free speech. Initially, I was a no. And then I came around to, yeah, it's just somebody making a determination what the variables and how they're weighted are in that algorithm. And that's as much, you know, a free speech opportunity as anything else.
I could see it when you start talking about blocking that, like the corollary becomes very concerning because you're blocking call it your next best conversation, right? And that's been a fundamental sales tool since the dawn of sales. So it's an interesting,
right? Or just like, I want to maximize my revenue, so I want an algorithm that it increases engagement. And if that means I have a platform that has a lot of idiots, so there's a lot more idiotic conversation, that's my choice, right? That's free speech. And so if I want more idiots, more power to me.
Well, this has been amazing. Thank you for your time.
And by the way, that's a great last question. That's the best last question I've ever been asked, and it's not even close.
His head didn't get any bigger, Mark. It's already enormous. This is
and I do a lot of interviews. But that one really made me think hard.
Well, good. And so tell everybody where they can find out more about Cost Plus and more about you and this effort to make things more transparent in healthcare.
Just go to costplusdrugs.com. And like you said, Epic and Cerner, we're at Mark Cuban Cost Plus Drugs. Please use us. Please spread the word. Please check us out. You'll be shocked, at the drugs that we carry, things that your PBM or your healthcare system or your insurance provider will say are specialty drugs. There's a really good chance that we carry it.
Excellent. Awesome. Mark Cuban, thank you for your time.
You guys are awesome. Thanks, guys.
Thank you very much, Mark Cuban, for joining the podcast for Doctors by Doctors. That was an incredible 2-part series and a broad run through of pharmacy, healthcare, policy, sports.
I don't remember any of that. All I remember is when he said that my question was the best question he's ever been asked in an interview. So I'm sorry. I'll have to re-listen to remember the other stuff.
I could see your head swell on our camera here, and I was afraid of that. I was honestly a little concerned. It's, at a certain size, there's engineering concerns, but it was pretty incredible. It was pretty incredible. Obviously, I think we've both been a fan of Mark and what he's been doing for so many years now, and his eagerness to dive into the healthcare space and to try to make things better for our community of doctors, for our community of patients out there. It was I'm kind of over the moon on it. Not going to lie. This is geeking out.
And I'm interested to see how this Cost Plus Wellness develops, as he talked a lot about. We talked some about in part 1, the Cost Plus Pharmacy and wellness, and kind of bled into part 2, I think. But of just this push of increasing the amount of information patients actually have access to, and that the other economic actors in the system have access to, so that greater transparency hopefully leads to greater efficiencies.
I think we've all been talking about more transparency in healthcare for a long time, since the ACA, so now more for more than 10 years now. We've all talked about and heard about the efficiencies gained with transparency. And although there's been some improvements made, without really collective action, it's going to be very challenging to improve from a policy standpoint. So I'm very excited to hear that that's the focus of it. It's not one unifying call like Medicare for all or universal healthcare, universal basic income. It's instead more broad that transparency will solve things.
And isn't it crazy? It's opaque to us and we're in it as doctors. Like, if it's opaque to us, then what is it like to anyone who doesn't work in it and hasn't been steeped in it? It's an incredibly inefficient and complex system, unfortunately. But I love the innovation, and smart people are starting to really think and iterate new ideas.
And to pay attention to it. I think there's been a recognition that there's money in healthcare, not always for the right reasons by the right people. I think what I heard from Mark is that there's absolutely options for opportunity and innovation here, and it doesn't have to be a version of piracy. You can do good, be good, and still find ways to succeed as a company, like he's done with Mark Cuban's Cost Plus Pharmacy, and then the Cost Plus and the Cost Plus Health, Cost Plus Wellness. Thank you. This is how unwell I am. I can't even conceive that there's a Cost Plus Wellness program out there.
Yeah. Well, hope you guys enjoyed it. Please don't forget to share this with all your friends. Spread the word on Cost Plus and the great work him and his company are doing for providers and ultimately for patients.
Thanks for joining us this episode. You can catch the podcast For Doctors by Doctors on Apple, Spotify, YouTube, and all the major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thank you for listening. And the next time you see a doctor, maybe you should prescribe this podcast. We'll see you next time.